this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's discussion. In today's discussion, we're in session number 6 of our ongoing program entitled Special Tests in the Chiropractic Examination of the Spine. And in this program, we're limiting our discussion to simply 2 conditions, the conditions of radiculopathy and myelopathy. And already to this point in the program, we spent great time talking about cervical radiculopathy and myelopathy, thoracic radiculopathy and myelopathy, and we spent our last session talking about physical examination procedures for lumbar radiculopathy. And in our next 2 sessions, I want to wrap up this program with 2 discussions that I'm sure you're going to find to be quite fascinating and immediately relevant to you in your clinical practice. In our next session, I want to talk about some diagnostic study findings in both radiculopathy and myelopathy, and I want to introduce to you a topic that may perhaps be new to you, and that has to do with an analysis of loss of motion segment integrity of your examinee's spine. Dealing with the cervical spine primarily, with the lumbar spine secondarily, and on a tertiary basis dealing with the thoracic spine. And for those of you that are involved in medical legal work, either personal injury and or workers' compensation, you may be familiar with the analysis involved with assessing for loss of motion segment integrity of the individual spinal segments. For those of you that are not, this may come as a new concept to you, but I believe it to be extremely valuable for all of us to understand, because a loss of motion segment integrity of the individual spinal segments is a great diagnostic tool and a great prognostic indicator as to your examinee's future condition, as well as their response to your treatment program. In other words, examinees can demonstrate improvement and functional restoration in individual spinal segments that previously demonstrated a loss of spinal motion segment integrity. So it can be a way to both diagnose your examinee's condition and also a way to measure their progress and their response to your treatment efforts. So that's going to be in our next session. In today's session, I want to talk to you about a physical examination procedure that's many times overlooked in the assessment of our spine injury cases, and that has to do with the formal gait analysis. Now, typically when we think of radiculopathy and myelopathy, our examination procedures consist of sensory testing, motor testing, and reflex testing. And we've spent great time in this series talking about how to do exactly those types of physical examination procedures. Well, oftentimes overlooked is an assessment of the examinee's gait. And it's quite fascinating because I have 2 references for you today to accompany today's discussion that reveal that many times an alteration in the examinee's gait is the first physical manifestation of developing radiculopathy and or myelopathy. So in other words, even before the examinee has subjective complaints, even before the examinee has objective physical examination findings of loss of sensation, of hyper or hyporeflexia, of increased or decreased motor strength, even before any of those manifest, the examinee can manifest an alteration in the gait, which can be easily observed if you'll simply take the time to do a formal gait analysis. So in today's discussion, I want to explain to you a simple and practical procedure to implement the formal gait analysis into your routine physical examination protocol. And then also I want to spend some time talking about the AMA guides and what the AMA guides have to say about gait derangements and gait disturbances and how alterations in gait can impact patients' activities of daily living. So this will come in handy and useful for those of you who are involved in medical legal work, and will also be valuable for those of you who are not involved in medical legal work, but who are involved in examining and treating these types of patients. Okay, so I have a great couple of sessions for you over the next 2 weeks. And with no further ado, let's get into today's discussion entitled The Formal Gait Analysis.
Now, according to Box 15.1 of the AMA guides, at least as far as the lumbar spine is concerned, the gait evaluation is required. And we've established throughout this program the necessity of the gait evaluation with regards to the cervical spine exam and also with regards to the thoracic spine exam. So it's interesting that the AMA guides ask us to evaluate gait, but give us no guidance or direction as to how it is that we're supposed to evaluate the gait. And so I put quite a bit of research into that topic, and I came up with a program. It's entitled Gait Disturbance and Assistive Devices. It's a 3-hour QME home study continuing education program. And at the bottom of this PowerPoint slide, for those of you that have the PowerPoint presentation, I give you a link to take a look at that program. It's actually a fascinating program. And as I mentioned earlier, I'm looking forward to expanding it to 6 hours because since I originally made that program over a year ago, I've learned so much about gait and assistive devices just because of increased awareness and increased interest actually about gait. I mean, once I started observing gait, everywhere I go, I see gait disturbance. I'll give you an example right now today, exactly today. As I'm recording this, it's approximately 3:10 p.m. in the afternoon. And earlier this afternoon around noon, I went out to do some errands and I went to Home Depot. And as I was pulling in the parking lot, crossing the path of the parking lot in one direction was a person with some kind of a gait disturbance. And just as I was trying to assess what the gait disturbance was, across my field of vision going in the opposite direction was another woman using a cane and had another type of gait disturbance. And meanwhile, traffic was piling up, and I couldn't focus on these people, but I noticed that the woman with the cane, she did not have her cane properly adjusted. She had a T-handle cane. And so right there was two people right in front of me with gait disturbance. So I then went and parked my car, and as I was heading into Home Depot, there was an elderly gentleman coming out of Home Depot pushing a shopping cart, and he had some type of a gait disturbance. And so as he passed in front of me, I stopped and I turned and I watched, and I noticed that he had a drop foot on the right. And he was very clever in disguising it. He probably had it for a long time, and he knew how to walk and work with it. He may have even had a brace, but I noticed that he had a total lack of dorsiflexion of his right foot. So once you get started thinking about gait and observing gait and doing a gait evaluation in your QME exams, you're going to find it to be fascinating because everywhere you look you see gait disturbances. So let's talk a little bit about the AMA guides and gait and some of the issues that we confront with gait as qualified medical evaluators. Now, first of all, I want to start this section out by giving you a quote from DeMeyer, Dr. DeMeyer, in his book, The Technique of the Neurologic Examination, 5th edition. He says that watching the patient walk is the single most important part of the entire neurologic examination, unquote. Now, that's a pretty strong quote. He says it's the most important part of the entire neurologic examination. And why would DeMeyer say that? Why would he make such a claim? Well, it comes down to the fact that in the presence of normal gait, for example, if your examinee is able to get up and out of their chair and follow your instructions to come back to the exam room, and they walk back to the exam room with no noticeable gait disturbance, no ataxia, no broad-based gait, no stumbling, no steppage gait, right? What does that tell you? It tells you that a lot of structures are functioning properly. In fact, just the ability to follow your instructions tells you that their sensorium, their central nervous system, and their mental function is intact. If they're able to walk without stumbling or falling, it tells you that their sensory system is intact. And if the sensory system is intact, then their motor system is intact. And if their motor system is intact, then reversibly the sensory system is intact. And so the ability to walk normally requires high-level neurologic function, and so it tells you a lot. In fact, DeMeyer says it's the single most important part. So I say that to you to encourage you to begin to do a formal gait analysis with every case. With every case. Now, there may be some cases that don't require a gait examination, but there are more cases that you would than you would think of that do require a gait evaluation than cases that don't. And I recently provided a permanent impairment rating for gait disturbance due to an upper extremity injury. And I'll just let that sink in for a minute. Yes, indeed, this person had an upper extremity injury, and I provided a permanent impairment rating due to gait disturbance. Because isn't it true that the upper extremities are involved with gait? Sure, it's true. We swing our arms in what's called reciprocal arm swing when we walk. And so you're going to find that the gait evaluation opens up many new considerations for you. I guess I'll just put it that way. Now, the AMA guides require an evaluation of gait in chapters 13, chapter 15, and chapter 17, but nowhere is there any mention in the guides as to how to perform the gait analysis. So let's go into that here now. So first of all, let's begin by defining gait. You know, what is gait? Well, according to Webster's dictionary, gait is a manner of walking or moving on foot. It's a sequence of foot movements, as in a walk, a trot, a pace, or a canter, by which a horse or a dog moves forward, a manner or rate of movement or progress. Now, we're not going to be examining horses or dogs, but this definition is illustrative. It still tells us that gait is a manner of walking. It's a manner of moving on foot. It's a sequence of foot movements by which we move forward as human beings. It's a manner or rate of movement or progress. So I've included a link for you, for those of you that have the PowerPoint presentation here. I've included a link to some videos of actual gait evaluations that I've done of some of my own injured workers. And I want you to ask yourself as you view these videos, is the manner of walking or the manner or rate of movement or progress, is it normal or is it abnormal? And see if you can start to zone in and hone in on some of the nuances involved with evaluating gait. Okay, so now that we know what gait is, let's define what a normal gait would therefore be considered. A normal gait would be a smooth manner of walking or moving on foot. A smooth manner. Smooth manner. Sometimes when you watch people walk, there's some interruption in the smoothness of the manner. A normal gait is a balanced sequence of foot movements. Balanced sequence. Sometimes you'll see people walk and their sequence is unbalanced. A normal gait is an unlabored manner or an unlabored rate of movement or progress. And sometimes when you watch people walk, their manner or rate of movement or progress is very labored. It's very in fact, it's laborious to watch. It's so uncomfortable, it's even hard to watch. It should be unlabored, should be smooth, should be balanced. Okay, so with those ideas in mind, what would an abnormal gait be? Well, an abnormal gait would be a disrupted manner of walking or moving on foot. It's an unbalanced sequence of foot movements. It's a labored or difficult manner or rate of movement or forward progress. Now, the AMA guides in Chapter 13, Table 35, provides for permanent impairment due to loss of balance and unsteady gait due to central and peripheral nervous system disorders. And according to the descriptions in the guides, impairments are based upon the amount of loss of balance and the unsteadiness or inability to move forward smoothly and to progress forward on foot smoothly with a normal gait. So, for example, Class 1 impairment in Chapter 13, Table 1315 is a person who's able to rise to a standing position. They're able to walk, but they have difficulty with elevations, grades, stairs, deep chairs, and long distances. So this is a Class 1 impairment. Now, the next level of impairment, the Class 2 impairment, is a person who rises to a standing position, walks some distance with difficulty and without assistance, but is limited to level surfaces. So I want you to picture that in your mind. I want you to picture that in your mind. This person rises to a standing position from the chair under their own power, walks some distance with difficulty but without assistance, but they're limited to level surfaces. So when it says that they walk some distance with difficulty, how would that look? It would look disrupted. It would look unbalanced. It would look labored. In other words, there would be positive objective findings for a Class 2 impairment. Is there positive objective findings with a Class 1 impairment? Well, let's review it. It says they rise to a standing position, they walk, but they have difficulty with elevations, grades, stairs, deep chairs, and long distances. What positive objective findings are you going to see with a Class 1 impairment? Well, you're not going to really see any unless you go out to some grades, to some stairs, unless you do some long distances with the injured worker. And what are the chances of actually doing that? But with a Class 2 impairment, now you're going to actually start to see positive objective findings, because you're going to see the difficulty with walking shorter distances. Now, the next level of impairment, due to central and peripheral nervous system disorders, and what do we mean by a central nervous system disorder? We're talking about here myelopathy. We're talking about injury to the cortical spinal tract. Or peripheral nervous system disorders. What are we talking about? Well, here we're talking about radiculopathy. Okay, so a Class 3 impairment, this is a person who rises and maintains a standing position with difficulty and cannot walk without assistance. Well, what kind of assistance? What kind of assistance? Well, that involves either an assistive device, such as a cane or a walker, or another person to help steady them along. So they are able to rise and they are able to maintain a standing position with difficulty, but cannot walk without assistance. This is going to be accompanied by positive, significant objective findings. And this person is going to have significant limitations in activities of daily living, obviously. Finally, Class 4 impairment is a person who cannot stand without help. Cannot stand without help. Cannot stand without help, cannot stand without mechanical support, and cannot stand without an assistive device. So what would this person look like? This is a person who pretty much needs bilateral crutches, bilateral canes, or simply cannot stand up without the help of another person present. And this is the highest level of impairment. Now, for Class 1 impairment, the AMA guides provide for 1 to 9% whole person impairment, and there's a range there for you doctors to select depending upon the impact of this condition on their activities of daily living. Class 2 impairment is 10 to 19% whole person. Class 3 impairment, 20 to 39% whole person impairment. And Class 4 impairment is 40 to 60% whole person impairment. Now let's contrast these findings with the descriptions of permanent impairments due to gait disturbance in Chapter 17. Now in Chapter 17, Table 17-5 is where we look for permanent impairments due to limp or due to use of assistive devices. Now, not due to central or peripheral nervous system injury, but here we're talking about injury to the lower extremities. So I mention this here just to contrast and compare the different impairments related to gait disturbances, because it's all going to come back to our gait evaluation, and depending upon the findings and our conclusions of the gait evaluation, we may analogize permanent impairments either according to Chapters 13 or Chapter 17, depending upon which description most closely and most accurately describes the permanent impairment of your examinee. So in Table 17-5, the mild impairments include the following. Includes number 1, an antalgic limp with a shortened stance phase and documented moderate to advanced arthritic changes of the hip, knee, or ankle. Okay, so that involves a limp, an antalgic limp, a limp away from pain with a shortened stance phase. Now I want you to picture what it looks like to have a shortened stance phase. Stance phase is the weight-bearing portion of the gait cycle, right? And with pain, whether that pain be due to lumbar spine radiculopathy or a knee replacement or a sprained ankle, with pain, your examinee is going to shorten the amount of time that they spend in the weight-bearing phase. And so that we call that a shortened stance phase. So by observation, you can observe this as a laborious manner of moving forward, an unbalanced and awkward manner of moving. They have a shortened stance phase. Now, in addition to physical examination findings, the AMA guides in Chapter 17 also require objective verification of pathology, and they require documented moderate to advanced arthritic changes of the hip, knee, or ankle. It's not enough simply to have an antalgic limp with shortened stance phase. The guides require objective verification of pathology. Also, mild impairment includes the positive Trendelenburg sign, which is another form of limp, and moderate to advanced degenerative changes of the hip. Moderate impairment includes the above limps, but also part-time use of a cane or crutch for distance walking, but usually not at home or in the workplace, or requires routine use of a short leg brace, with generally an ankle-foot orthosis type of short leg brace. So those are the mild impairments. And for those of you that have the PowerPoint presentation, I include a link here to a video that will help you to determine excuse me, the medical necessity of a cane. because it may be possible that your examinee shows up to the exam with a cane. And so I include some training material for you here to help you determine the medical necessity of that cane. Okay, then the moderate impairments are further described in Table 17.5. Moderate impairments require routine use of a cane, routine use of a crutch or a long leg brace, or requires routine use of a cane or crutch and a short leg brace, or requires routine use of 2 canes or crutches. So I want you to envision this injured worker coming into the examination room. Okay, imagine an injured worker coming in with 2 canes or 2 crutches. Okay, that's a significant positive objective finding, correct? Okay. Routine use of a cane, routine use of a crutch, or routine use of a long leg brace. These are assistive devices. And how would you assess an assistive device for routine use? Well, you might assess these devices by looking at the amount of use that they're getting and the amount of wear and tear that they display. That may give you some indication as to how much these assistive devices are actually being used. Those are the moderate impairments. And then the severe impairments are not going to be difficult to be able to detect when the examinee comes into the appointment. Severe impairments require routine use of 2 canes or 2 crutches and a short leg brace, or requires routine use of 2 canes or 2 crutches and a long leg brace, or requires routine use of 2 canes or 2 crutches and 2 lower extremity braces, or your examinee is simply wheelchair dependent. Now, these are obvious gait disturbances that doesn't take a genius evaluator to be able to detect. And these are significant bona fide, there will be significant bona fide positive objective findings throughout your activities of daily living assessment, throughout your observation, and throughout your physical examination that would substantiate these levels of impairment. Now, the mild impairments in Chapter 17 carry a 7 to 15% whole person impairment. The moderate impairments carry between 20 and 40% permanent impairment. And the severe impairments, such as being wheelchair dependent, carry between 50 and 80% whole person impairments. And those ranges are provided for us to have some latitude in ascribing permanent impairment based upon the impact of those gait disturbances on activities of daily living. So now that we know that some of the observations that we're going to be looking for in the gait evaluation, how do we actually do the gait evaluation? Well, the gait evaluation actually begins even before meeting the injured worker. And part of this comes down to some of your preparation as a qualified medical evaluator. And I discussed this at length in another program entitled The 21 Secrets of the Most Persuasive Qualified Medical Evaluators. In that program, there's a section of the program entitled The Preparatory Secrets of the Most Persuasive QMEs. And if you know in advance that you are going to be evaluating a person with a spine injury or a lower extremity injury, and as I said earlier, even in the case of an upper extremity injury, be prepared in advance to do a gait analysis and plan that out as to when in your evaluation you will actually do the gait evaluation. In other words, you need to be prepared in advance, or it simply is going to get overlooked, or it simply won't get done, or something will be omitted. So part of the preparation for your appointment is to prepare the formal gait evaluation in advance. But actually, before you even meet the injured worker in the face-to-face evaluation, you are observing the injured worker for the potential presence of a gait disturbance. So let's go over some of the steps to the gait analysis. Step number 1 is to observe, and I'll expand on each of these here in just a minute, is to observe the examinee. Number 2 is to interrogate the examinee. Number 3 is to define any gait disturbance that you may find present. Number 4 is to videotape any gait disturbance that you may find to be present. And then number 5 is to review all your findings, including your videotape, later on your own time, to review all your findings for consistency. Consistency. So what does it mean when we say observe the examinee? Well, some of the things that you're going to observe when you go out to meet the examinee in the waiting room is the presence or absence of an assistive device. And this might not sound like rocket science, but sometimes assistive devices may be hidden. A knee brace may be something that's hidden. An ankle dorsiflexion splint in the case of a drop foot might be something that's hidden. Certainly crutches and walkers and canes would be immediately visible, but some others may be hidden, so you want to be observant and looking for the possibility of the presence of an assistive device. Another thing that you want to observe is you want to observe how does the examinee rise from the waiting room chair. Is there a positive minor sign when rising from the waiting room chair? And recall that a positive minor sign is the need to use the hands to either push off the chair or to push off the thighs in order to generate the initial power and momentum to get up and out of that chair. That tells you something. That tells you that there's either pain or some type of weakness and that they don't have sufficient strength to get out of a deep chair, and that does qualify as permanent impairment. So there's one finding that could support a finding of permanent impairment due to gait disturbance. And then finally, you want to observe the examinee as they move from the waiting room to the examining room. And what I generally do is when I meet the injured worker, I'll go out and shake their hand, and I'll introduce myself, and I'll look them in the eye, and then I'll motion for them to come with me back to the exam room, and I'll take a couple of steps backwards, walking backwards, that is, to give them space to get out of their chair, and then I'll continue walking backwards towards the examination room as they follow me, and this gives me a chance to observe them from their front, and I get a good idea as to how they're moving from the waiting room to the examining room. I can start to draw some initial conclusions simply from this very brief 5 to 10 second interaction out in the waiting room. Next step in the gait analysis is to interrogate the injured worker. And perhaps interrogate's too strong of a term, but what I mean by that is we're going to ask the injured worker, and we're going to ask for their help as to helping us to identify any gait disturbance that may be present. So as the examinee is walking back to the examining room, you can simply ask them about their gait. You can ask them, can you walk okay? Do you have any kind of a limp? Do you have any kind of pain with walking? Are you able to walk normally? How's your walk? Looks like you can walk okay. Are you walking okay? So you interrogate the injured worker, because many times some of these gait disturbances may be subtle, and you might not notice anything obvious in the short distance between the exam room and the waiting room. And that's where you can solicit or elicit the examinee's help in helping you to define whether or not there actually is some sort of a gait disturbance. Now, if the examinee answers in the negative, meaning they say that no, they don't have any kind of gait disturbance, they don't have any kind of limp, they can walk okay, they're fine, then in essence, the gait analysis is pretty much over. If you don't observe a gait disturbance and the injured worker themselves denies any type of a gait disturbance, then basically you're done. If the examinee, on the other hand, does admit to some type of a gait disturbance or a limp or a pain, then that's something that you're going to have to investigate a little bit later on more formally in your formal gait analysis. Okay, so with the formal gait analysis, what you're going to do is you want to observe the gait from at least 3 positions. At least 3 positions. Well, what 3 positions? Well, from the front, from the back, and then from the involved side. So, for example, if this injured worker has a L5 radiculopathy that's caused a drop foot on the left, you're going to watch that injured worker. You're going to watch the injured worker as they walk towards you, as they walk away from you, and as they walk alongside of you with yourself positioned to the left side to have a clear vision of the left drop foot. Then, in the presence of some type of a gait disturbance, you're going to ask the examinee to help you define or help characterize the nature of the disturbance. And this is sometimes not easy to do. As I said, you get better at it with time. But in the beginning, you might not be very good at defining or characterizing the gait disturbance. You might be pretty good at detecting that there is some kind of a gait disturbance, right? There's some kind of a gait disturbance. In other words, you notice that there's some kind of a shortened stance phase on one side, but you don't know if it's the back is hurting or there's a weak leg or there's a drop foot, but you do see a shortened stance phase, and you know that there is some kind of a gait disturbance. It takes a little more time to be able to accurately define and characterize what exactly is the gait disturbance. And I'm reminded of an experience I had recently. I was visiting my parents in Oregon, and my father and I, we were going out to lunch, getting a sandwich at a supermarket. And as we entered the supermarket, I saw this woman entering the supermarket in front of me, and she had a gait disturbance. And I was able to watch her for 10 or 15 steps. In other words, I got a good look at her. And I concluded that she had a problem with her right knee. And as we both were trying to get our shopping carts unstuck from the long row of shopping carts, I had the occasion to ask her, how's your right knee? And she said, well, it's okay. And I said, well, I saw you have a limp. And she says, well, I'm limping because of my back. And I said, well, that's interesting. I saw that you're limping, and I wasn't exactly sure what was bothering you, but as I watched you, I thought that it was possibly your right knee. And she said, yeah, you're right. I'm actually having a problem with my back and my knee. And so I turned out to be right, but I could have just as easily been wrong. And so the point is, you're going to ask the examinee to help you to define and characterize what exactly is the problem. And they'll tell you. They'll say, oh, it's my hip. When I step down, I get a shot of pain in my hip, and I got to get off of it. Or it's my knee. I can't bend my knee beyond this, or whatever it is. And so once you get it defined and characterized, once you get the disturbance defined and characterized, you want to confirm your definition through repetition. So that's the beauty of having the injured worker walk towards you, walk away from you, and walk alongside you. You get to have them repeat, and repeat the stretch of distance, and you get to observe and further characterize what exactly is the gait disturbance. And then what I recommend and what I do, and I have an entire library, is I recommend you videotape the gait. Again, you videotape it from the front, from the back, and from the involved side. And I'll generally have an examinee walk 20 to 30 to 40 yards, either outside in a parking lot or along a long sidewalk. In other words, we do this outside. We do not do this inside the examining room or down a long hallway. We go outside and we actually do a formal gait analysis. And it's not unusual for me to take 4 to 5 to 6 videotapes from multiple different directions with zooms and close-ups and what have you. And so once this is all done, then you have both your recollection and you have hard copy videotaping that you can then later take back with you to your office to review for consistency. And all components of the activities of daily living assessment, the interview, the exam, the gait analysis, they should all be consistent, even consistent with findings on diagnostic studies as required in Chapter 17, which requires radiographic evidence of moderate or advanced degeneration of one of the involved joints. So all of these components should be consistent, and you can review for consistency on your own time back at your office with the help of your videotaping. So let's review the gait analysis. And remember, what we're talking about here is we're talking about some of the special tests that are required in the QME examination with regards to the spine anyway. In the cases of either myelopathy or radiculopathy, the guides require us to do a gait evaluation, but they don't tell us how to do it. So I'm proposing a method here for you to use that I've used now for 5 to 7 years with hundreds and hundreds of injured workers, and it works beautifully. And so let's just review it here. The gait analysis, where it begins with an observation even before you meet the injured worker in the examining room. It begins with your initial observations and your initial movements of them, moving from the waiting room to the examining room. Then it proceeds with interrogation, where you ask the examinee if they believe that they have any kind of gait disturbance, limp, or any other type of compensation. Next, observe and define the disturbance. Watch from the front, from the back, from the side, and with the examinee's help, characterize what exactly is the disturbance of the gait. Then videotape from the front, from the back, and from the side of the affected lower extremity. Then on your own time, you can review videotaping and observe for consistency with the physical exam findings. So let's get into now a description of the phases of normal gait. And we're going to break down the gait cycle into several sub-phases and describe those sub-phases as they would appear in the presence of normal gait. And once we have an understanding of what normal gait looks like, then we can go into a description of what abnormal gait would look like. Now, the cycle of one limb, as it first touches the ground in front of the body, then 2 as it moves behind the body, and then number 3 as it comes back into contact with the ground again. This is known as the gait cycle. Now, to analyze the gait of your injured worker, you begin by looking at the beginning point of the cycle, at initial contact of the foot with the ground. Okay, you then follow the foot as it passes behind the body, and then you follow it forward until it contacts the ground again. This is one complete cycle. Now, this cycle has been broken down into the millisecond by researchers and kinesiologists, and that, of course, would be on that type of analysis would be on the scope of this program, and it's not necessary for the QME examination, however. But some detail about the phases of the gait cycle will make an analysis of normal and abnormal gaits easier, and therefore more descriptive in your report writing. And so we're going to go over some of those phases here in this program. Now, the period of time when the foot is in contact with the ground, that's known as the stance phase. When the foot is in contact with the ground, that's known as the stance phase. The stance phase is the weight-bearing portion of the cycle. The stance phase, let me repeat that. The stance phase is the weight-bearing portion of the gait cycle for that foot. And in this case, we're talking about the left foot. Now, the period of time when the left foot is off the ground, that's known as the swing phase. And the swing phase is the non-weight-bearing portion of the cycle for that foot. Talking here again about the left foot. Now, throughout the gait cycle, 60% of the time is occupied with the stance phase, and 40% of the time is occupied with the swing phase. So 60% of the time is weight-bearing. 40% of the time is non-weight-bearing. And understanding this ratio, 60-40, makes it easy to detect what is described in the AMA guides as, quote, an antalgic limp with a shortened stance phase, unquote. Shortened stance phase. So with a shortened stance phase, or a shortened weight-bearing portion of the phase of gait, the ratio of 60-40 starts to change, and that 60 starts to become a smaller number. In fact, we might see a 50-50 type of ratio between the stance phase and the swing phase, or even less time involved with the weight-bearing phase. And this becomes quite easy to detect when it's present. Now, the stance phase can be further broken down into several subphases, including the heel strike phase, the mid-stance phase, and the push-off phase of gait. And because the stance phase occupies the majority of the gait cycle, we're going to take a look at each of these subphases in a little bit more detail. Then the swing phase, that comprises 40% of the gait cycle, and we'll get into some description of some normal and abnormal findings of the swing phase of gait as well. Okay, so let's talk about the heel strike phase of gait and findings that we would see in the presence of normal gait at heel strike, and some possible deviations from the normal gait in the presence of pathologic conditions. Focusing all of our attention now on the heel strike phase of gait, and in this example we're again talking about the right foot. Yes, these examples that we're going to go through now discuss normal phases of gait with the right foot. Okay, so at heel strike, this begins with the initial contact of the heel on the ground. And if we focus our observation on the right lower extremity from a lateral view now, we find that in normal heel strike, the head and trunk are vertical. The right arm is slightly posterior to the midline of the body with the elbow slightly extended. And let's just think about this for a minute, doctors. With right heel strike, the right arm is slightly posterior to the midline of the body. So as the right leg comes forward, the right arm goes backwards. Well, as the right arm goes backwards, the left arm is slightly anterior to the midline of the body with the elbow slightly flexed. The right knee is extended, but it's not locked, and the ankle is in slight plantar flexion. Now, take a moment to picture this image in your mind. Picture in your mind the image of a person walking normally and focus in on the heel strike phase. Okay? Head and trunk are vertical. The right arm is slightly back of the body. The left arm is slightly forward of the body. The right knee is extended, and the ankle is in slight plantar flexion. And that makes sense. As the heel strikes the ground, the ankle starts to move into slight plantar flexion. Now, in the presence of pathologic conditions, in other words, problems, injuries, trauma, some common observable deviations from the normal pattern that we might see would include a forward shifting of the head and trunk. In other words, the head getting ahead of the midline of the body. We could see that the right knee is locked in extension or hyperextension, or we could see that the knee is flexed and fails to achieve extension. We could see that the foot lands flat on the floor, or even that the toes land first on the floor. The forefoot and toes may slap the ground. And create a mental image picture of each one of these deviations. Picture an injured worker with his body ahead of his head and trunk ahead of the legs. Picture the knee partially flexed and failing to achieve full extension. Picture the toes landing first on the ground and slapping on the ground. I recommend this, visualizing these in your mind, because seeing them first in your mind makes it easier to identify these deviations in the physical world when and if they are present. So go through this exercise in your mind, and therefore the next time you see an injured worker with these deviations, you will have already seen them, and you'll instantly recognize those when they're present. Let's talk about heel strike now from an anterior view. What would it look like if we were to evaluate the injured worker, this time looking at them from the front? Well, again, focusing in on the right lower extremity, at heel strike, we find that the head and trunk are vertically aligned. We see that the arms swing at an equal and symmetric distance from the body. Now you're looking at the injured worker from the front, and he's walking towards you. So the arms should swing at an equal distance from the body. We see that the pelvis lists slightly inferior on the right side, on the weight-bearing side. We see that the right thigh and leg are in vertical alignment with the pelvis. And as the injured worker walks towards us, we see that the plantar surface of the foot is visible approximately 10 feet away from the examinee. As the examinee walks towards us, we start to be able to see the plantar surface of the foot. Now, in the presence of pathologic conditions, in other words, following injury or following trauma, we see some deviations from those normal findings. As the injured worker walks towards us again from an anterior view, we see that the trunk is displaced either to the right or to the left. And more common would be a leaning to the right towards the weight-bearing side. We could see that the right hip is in lateral rotation. We could see that the right hip is in protective abduction in order to broaden the base of support. So we would see that that right hip moves away from the right hip and leg moves away from the body to contribute to a broader base of support. And we could see, for example, that the plantar surface of the foot is not visible. That would be a sign of limited dorsiflexion of the foot. So take a moment to visualize some of these findings in your mind's eye. Okay, let's take a look now at the mid-stance phase of gait. This is the main weight-bearing portion of the stance phase, is the mid-stance phase of gait. Now at the mid-stance phase of gait, the body's center of gravity is now over the base of support. So looking at the right foot now from the lateral view, with the body's center of gravity over the base of support, we should see that the head and trunk are vertical. Both arms are near the midline of the body with the elbows slightly flexed. Of course, the elbows are going in opposite directions. One's coming forward and one's coming backwards, but they're meeting at the midline as they pass through opposite directions of motion. We see that the knee, the right knee, should be in slight flexion, and the right ankle is in slight dorsiflexion now, as the body moves over the base of support. In the presence of pathologic conditions, we see that the head and trunk now become shifted either forwards or backwards of the hip joint, so that the center of gravity becomes placed either forward or backwards of the base of support. We see that the knee is locked in either extension, hyperextension, or in a position of exaggerated flexion. You might see that the ankle is found to be in exaggerated dorsiflexion. Now, what about from the anterior view? From the anterior view, as the injured worker walks towards you, the head and trunk are vertical, and the arms are at an equal and symmetric distance from the body, and the pelvis possibly could lift slightly now to the left side, and the right hip has a slight lateral rotation. And this is describing a specific type of gait, and I'll reveal that to you here shortly, but for now just picture this in your mind. Now, in the presence of pathologic conditions, the head and trunk tip to the right. Head and trunk tip to the right. The pelvis tilts upward on the left side with the right arm away from the body, or possibly the pelvis has an exaggerated lift to the left side, to the opposite side. Other findings could include an exaggerated outward rotation of the hip and or varus or valgus positions of the foot, and just picture those in your mind, varus or valgus positions of the foot. Okay, so those are some findings in the mid-stance phase of gait. What about in the push-off phase of gait? Okay, so now the foot is moving behind the body. The heel rises from the ground, and the foot is just about getting ready to enter the swing phase of the gait. Well, again, looking at the right foot from the lateral view, in the presence of normal gait, we would see the right arm would be anterior to the midline of the body now, with the elbow partially flexed, and then we would see that the left arm is slightly posterior to the midline of the body, with the elbow extended. Pelvis has an anterior tilt. The right knee is partially flexed. The ankle is in plantar flexion now, and the toes are in extension at the metatarsal phalangeal joints as the body weight gets pushed off by the toes at the metatarsal phalangeal joints. In the presence of problems such as injury or trauma or pathologic conditions, we see that the arms would be an uneven distance from the midline of the body. We would see that both elbows are flexed. The pelvis has an exaggerated anterior tilt. Possibly the knee could be forcibly extended. The ankle plantar flexion may be limited, or the ankle may be in a position of dorsiflexion, and the metatarsal phalangeal joints may be neutral rather than in extension. And that would be common in problems with the foot, for example, pinning of the metatarsal phalangeal joints or of the phalangeal joints following perhaps a crush injury to the toes. And if we look at the injured worker from the posterior view at the push-off phase of gait, in the presence of normal gait, we would see that the arms are at an equal distance from the body. The right elbow is partially flexed, the left elbow is extended, the right hip is slightly laterally rotated, and now the plantar surface of the heel and midfoot are visible, while the forefoot and toes are in contact with the ground or the floor. In the presence of pathologic conditions, we would see, for example, perhaps that the arms could be at an uneven distance from the body. Finally, while the swing phase comprises the lesser portion of the entire gait cycle, approximately 40% of the entire cycle, deviations in swing phase are sometimes even more evident than are deviations found during the stance phase of gait. So let's go over some normal and abnormal findings that we might see in the swing phase of gait. Now again, looking at the right foot from a lateral view, in the presence of normal gait, we would see that the arms are near the midline of the body. The pelvis has a very slight anterior tilt. The right hip joint and right knee joint are both slightly flexed, and the right ankle is in slight dorsiflexion. In the presence of pathologic conditions, you could observe a posterior tilting of the pelvis. You could observe that the right hip and right knee flexion could be exaggerated. You could see that the forefoot is dropped into plantar flexion and that the toes drag on the floor. And take a moment to visualize this in your mind's eye. This is describing the so-called steppage gait, or the equine gait, found in weakness or dysfunction of the anterior tibialis muscle. And there's many different causes of dysfunction of the anterior tibialis muscle. Now, from the anterior view, and again just viewing the right lower extremity, normal mid-swing phase would be characterized by having the head and trunk vertical. The arms would be at an equal distance from the body. The pelvis has a very slight list to the right. The right hip is in very slight medial rotation, and the right ankle has slight eversion, the purpose of which is to help the toes to clear the ground. Now, in the presence of pathologic conditions, you might observe that the trunk leans to the left, pelvis is lifted on the right side, the right hip is abducted, and the leg may be circumducted in an arc in order to help the leg clear the ground. And the hip is laterally rotated, and the forefoot is dropped into plantar flexion. Now, these are just some examples of many of the possible different types of deviations in gait, and you've likely observed others. And these examples are just given to help you sharpen your interest in the observation of gait in your injured workers. And I recommend an exercise that you can do to sharpen your awareness of gait, and that is to observe gait in the public, out in the public, whether you're at the supermarket, at the mall,
Okay, doctor, so I hope you found that to be interesting, helpful, and relevant to your very next examinee in your clinical practice. And I want to encourage you to adopt the formal gait analysis into your routine protocol. And it's quite easy to do, and you don't need to make a big deal about it. Remember, according to Webster's dictionary, gait is defined as a manner of walking or moving on foot. So your job is to simply observe the patient's manner, the manner with which they walk and move on foot. And normal gait will consist of a smooth manner, an unlabored manner. Conversely, alterations in gait can be easily manifest and easily detected as a labored manner or a disrupted manner or a unsmooth, not rhythmic manner. And while it may not always be easy to determine the cause of a gait disturbance, in other words, is the cause of the gait disturbance coming at the hip? Is it coming at the knee? Is it coming at the ankle? Is it coming at the spine? It may not always be easy to identify the cause of the gait disturbance. It's usually very easy and quite easy to determine the presence of a gait disturbance. So once you identify the presence of a gait disturbance, you don't need to go it alone from there in terms of identifying the cause of the gait disturbance. You can ask for the examinee's help and ask them to help you come together. You and the examinee can come together and arrive in an agreement as to the cause of the gait disturbance. So you don't have to go it alone in that determination. Your job is simply to observe the examinee's manner of moving on foot and determine whether or not a gait disturbance exists or whether it does not exist. So simply take your examinee out to the parking lot, observe them to walk to and from a fixed point, approximately 30 yards out into the distance, and observe them from the front and from the side of the involved extremity, and you will certainly be able to capture and characterize 99% of the gait disturbances that you encounter. So this is an extremely valuable procedure, and your examinee will appreciate you for taking the time and the interest in performing such in-depth physical examination maneuvers that no other practitioner will take the time or effort to employ. So your examinee will be greatly impressed, and this procedure will provide great diagnostic insight into your examinee's condition, and also will serve as a source of physical examination improvement, a sign of physical examination improvement in your examinee's condition as your examinee recovers from any pre-treatment gait disturbance that they may have presented with. So I hope this helps you. This is Dr. Perry Carpenter. I want to thank you for taking the time to join me on today's discussion. I look forward to being with you on our very next discussion regarding diagnostic studies in the assessment of radiculopathy and myelopathy. And for now, I'm wishing you best of success in your career as a chiropractic